Hello, everybody. Welcome back to the CHNC Symposium. We're joined by Dr. Monty Sharma from Children's Nebraska. Nebraska. Not Children of Nebraska. I don't know.
It is a brand new name. It
Right.
is now, it used to be the Children's Hospital and Medical Center of Omaha. But we've branched out to Children's Nebraska since we are for all of Nebraska.
That's awesome.
You know, it's funny how hospital systems do that. Anyways, I'll digress, but they just try to keep it fresh, I feel like. So every few years changing
part
their
of
names.
3 of those.
Yeah, it's a little bit annoying.
Well, because then you need new apparel,
right.
and you got to change that stuff around.
You
right.
don't, because then you keep the old one and you're the OG. And so like, I've been here since
They
it
know
was
you've
called.
been a long time.
Since it was children. Yeah.
I remember when.
Since it was the infirmary.
That's right. That's awesome.
So tell us a little bit. You presented yesterday at the BPD workshop.
Yeah, so I'm a neonatologist and pulmonologist, and I presented on neonatal interventional bronchoscopy.
Tell us more. So for the people who who weren't at the workshop, distill a little bit in a few minutes. Like, what are some of the takeaways that you wanted to leave people with when it comes to that specifically?
Yeah, so I'm not sure how familiar people are with flexible bronchoscopies and laryngoscopies that pulmonologists do.
Probably not very.
Yeah.
Up until a few years ago, we were really limited by equipment. Like, a lot of the equipment was reusable. It had to be sterilized. It lived on large OR carts.
Yeah.
When you needed to use it, you'd basically have to mobilize an entire OR staff, bronchoscopy technician, nurse, from the OR, et cetera. So it was quite cumbersome. More recently, I think, especially through what we all went through in 2020, companies started to put out more flexible products and more disposable products. And these things started to become smaller and smaller. So the technology, instead of having to lug this giant thing over to the NICU, now you have this tiny little portable system that can go to the bedside.
I think our CMAC came with a flexible scope.
Yep.
Yes.
And we all were like, what are we supposed to do with it?
Well, so that's where I come in.
Right, that's right. But we have used it.
Yeah, we did. Yeah.
With assistance.
Yeah, and that's what we started to do. We said, well, why are we moving the baby to the OR?
Yeah.
Why are we not just bringing this technology to the bedside?
Yeah.
And so we started to do that at our level 4, which is our main hospital as far as multi-specialties go. So we'd be able to take this over there. And then eventually what we said was, well, wait a minute, why don't, instead of having to transfer a baby from a level 3 delivery hospital to the level 4, why don't we just bring this to the level 3 as well?
Right.
So we started to do that, and actually were met with a lot of success. And for most of the scopes we do, we started to find ways where we didn't have to actually intubate patients to do evaluations. So we initially started by doing nasendoscopy, so through the nose, evaluating the upper airway. Many of the people that trained me and had training previously were comfortable actually scoping even beyond the vocal cords through a nasendoscopy. So we started to do this for airway malacia evaluations. We also found that for some of the kids that we have in our NICUs who are non-invasively ventilated but on positive pressure, we could do the same thing through an LMA. So now we started to utilize these new small size 0.5 LMAs for that same purpose. So we have to minimally sedate kids for the most part. We use lidocaine on the vocal cords and the carina so they're not coughing. So we desensitize those receptors, and we could look beyond the vocal cords and give a really clean airway evaluation for setting up potential interventions. I think people are familiar with John Levin's work, who's over at Boston Children's. He's done a lot on airway malacia and potential interventions such as tracheoscopy, tracheopexies, or aortopexies. So we actually started to pre-evaluate kids for those kind of procedures.
Very cool. And so I'm assuming the use case for these interventions would be very different based on whether you are going out to a level 2, and I'd be curious how far out you go to do these evaluations versus the context in which you presented yesterday, which is in the context of BPD, where in my experience the scoping of these infants tend to come quite late in the course, right? They don't tend to get scoped early on. What can you tell us about that?
Yeah, that's a great point. So we do, for the patients with BPD and true potential alveolar simplification related disease, we do not scope until they're about 42 to 43 weeks corrected.
Yeah.
One of that is technology limitations. We want to make sure that our scope can safely go beyond the vocal cord, and we don't cause damage just with the scope passing through. The other thing is for treatments for some of these things, this disease is not like laryngomalacia. It gets better. Tracheomalacia, bronchomalacia probably have a faster rate of improving compared to laryngomalacia, and as a result, doing it too early, you're going to have a high false positive rate, and then you'll be doing procedures at a younger and younger age.
Yeah.
So we do it, and actually what we find is that we end up intervening less because then you have this beautiful picture, people see exactly what's going on, and seeing oftentimes ends up being believing, and therefore we're able to leave these kids and a few weeks later reassess if we need to.
I love that. I personally feel like we don't do enough bronchoscopies, right? Like we take a lot of x-rays. Now we're really excited about ultrasound, but we have this, you know, I wouldn't say non-invasive, but pretty well tolerated that can give us the best anatomic picture that we can get. So tell us
especially when you remove the anesthetic component.
For sure.
When you remove the patient transport from the equation, it becomes a very low friction study.
Yeah. So what is the scope of what you think we? But I'm no pun intended. Of what we could be doing. With what we could be doing with bronchoscopy. I mean, we especially like the dynamic component of the evaluation, but.
So I think what's more accessible in the immediate sense, especially since we figured out how to go through LMAs that they're well tolerated, is you can probably, one of the things I would love to see is the ability to intubate through them, right, for those difficult airways. Because I think the smaller LMAs, and not to sound like an advertisement for an LMA, but I think that's a great airway stabilization tool.
Yeah.
As we started to
I think we don't reach for LMAs often enough. It's not until after
especially compared to the older.
For sure.
I mean, my brother-in-law, an anesthesiologist, I think the LMA is like
right there.
Right there. Like they pull the LMA as if it's like a Band-Aid, you know. And for us, it's like, where are the LMAs?
That's right.
And sometimes it's almost treated like a scary tool.
That's
like we're using it, that means that something is truly wrong, and it should be like let's use it to stabilize.
For sure.
Right. And that's actually what we found is that I always make the trainees or the NNPs put the LMA in. We're not the ones doing it. They're the ones managing the airway. That way they get practice putting it in. They get direct feedback when the scope goes in. Hey, it's well positioned.
So
I think that's an easy thing is like intubating over it. Like if you know you have a difficult airway, micronathia, things like that. I think the more interesting thing down the line, especially in the BPD population, would be the potential deployment of resorbable stents, right? There's people working at different institutions and have tried it in adults, but these would basically be stents that could expand things while things are getting better and then dissolve away. Because retrieving stents can be kind of challenging.
Sure.
Yeah.
And this may potentially reduce the need for tracheostomy in some of these patients.
Potentially. And we've actually been prospectively following these kids. Dr. Levin's work really showed that they were doing a lot of these in kids who already had tracheostomies to potentially lower the PEEP burden. And that was one of the big takeaways from what we presented yesterday, was that, hey, by doing tracheopexy at the moment, what you're trying to reduce is the PEEP-related cardiopulmonary dynamics. But as we've started looking prospectively at some of these kids, we're trying to keep track and say, hey, well, maybe there's a subset of kids who have large airway disease, but relatively good lower airways. And maybe these are the kids that we can get out of the hospital sooner and potentially avoid a tracheostomy. Our numbers are very anecdotal at this point, but there might be a certain subset of patients that fit that this might be a good way to evaluate.
You're hoping there's a signal.
We're hoping, right? And I think that has to be looked at, of course. This is the classic thing at a multi-center level, but that requires more people being trained.
All right, with the disclaimers. You're excited about it. That's all we need to.
But you know, I'm interested. We're always talking about, say, I'll go back to tracheostomy, timing of tracheostomy. But I think there's some babies where we're really prolonging the inevitable. But if we had the anatomic picture where we say, I mean, this kid's going to need it based on what's going on with their anatomy, not just this bucket of BPD, it would get
something
babies
that
home
one
sooner.
more course of DART is not going to fix.
That's right.
Well, exactly,
that's right.
And it might
or
even
like,
make it
let's
worse.
Slower. Yeah, let's just take longer. And then I mean, now the kids, they're months and months where it's unnecessary.
And you need that functional assessment, right?
Sure.
When we do these studies under anesthesia, if you see it, it's there. If they're fully anesthetized. If you don't see it, that doesn't mean it's not there, because it's so dynamic. And that's kind of what the big takeaway was. When you do this at the bedside, it's a better dynamic evaluation for airway malacia. You're seeing it at a more functional baseline, right? And if it's not there and the scope is in the airway, that's giving you a lot of information. So I think that's what the big thing was. I'm glad you mentioned ultrasound, though, because one of the things we're now doing is simultaneous diaphragm ultrasounds as we're PEEP titrating to see if we can pick up a signal there.
Very cool.
So that is up and coming.
So lots of things coming down the line. I have a question about your training background.
Yeah.
Right? I think more and more neonatologists are subspecializing, let's say subspecializing.
Yeah.
So you're a pulmonologist and a neonatologist. How many of you are there in the country?
Oh, gosh. There are probably about 5 of us or 6 of us at the moment. I've been trying to collect everyone.
That's
so
right.
if you're a neo-pulm
You weren't
person,
looking around the room as if they were all here.
Well,
He's going to say yeah, there's John and Mary is right there.
John's not here, but there's
So
about
they should contact you
They
then.
should contact us. Maybe we'll set up, a very basic WhatsApp page, meet up at
Very
PAS, and grow from there.
I love that.
But I do think more and more people are getting interested in it. I think I found my training to be very enjoyable.
Yeah.
I think I'm hoping more people get interested. That's one of our hopes, is that this becomes more accessible.
And I think it's neat. I think we find that there are some pulmonologists that just do not want to come to the NICU. So maybe we have to train our own, I guess.
Yeah, right. That's to make them comfortable in the
Yeah.
NICU. So
That's great.
That's where I kind of got into this from.
Thank you, Monty, for dropping by, and congratulations on this great work. Take care.